Supporting these patients is so important. Really, we want to make sure that we're screening these patients and screening them early at every visit, whether that's with a PHQ-2, PHQ-9, using any of the clinical tools, and just checking in and being able to intervene early with medication and counseling if they meet the threshold for treatment. Since cancer in pregnancy is such a rare occurrence, as I mentioned earlier, only about 1 out of every 1,000 pregnancies, there probably won't be a lot of options for big in-person peer support groups, and especially during the pandemic, those were limited anyway. But there might be some good resources online for this. And I know where I work, our social work team is always really great with linking patients with these kind of resources, including financial resources as well.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. Today we are talking with ONS member Chandley Silin, nurse practitioner at the Stanford Cancer Center, Palo Alto in California, about caring for pregnant patients with cancer. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thank you for joining us today, Chandley.
Thanks for having me, Stephanie.
So, our patients that we care for that have cancer diagnosis, there are so many things that we have to talk with them about, care for them, educate them on. And today, our topic of patients that are pregnant is even kind of like that extra piece that we don't anticipate having to deal with when we're taking care of our patients. So to start us off, can you talk about what are some of the commonly diagnosed malignancies that happen during pregnancy or might come up during a pregnancy?
I'll start by saying that a cancer diagnosis during pregnancy is a very, very rare event. It happens once in only about every 1,000 pregnancies. And when it does happen, most common malignancies are melanoma, breast cancer, cervical cancer, and then also leukemias and lymphomas. This actually follows along with the overall incidence of these cancers in the general population of women of childbearing age. Although interestingly, Hodgkin lymphoma is the most commonly diagnosed of the hematologic malignancies diagnosed during pregnancy. Although in terms of overall lymphoma diagnoses, it only makes up about 15% of those. So that's an interesting fact.
It doesn't seem like the norm of the patient population that most oncology nurses see, the women of childbearing age. So let's then talk a little bit about the relationship between cancer and pregnancy. It's not something that's very well understood. Can you talk a little bit about that and the pathophysiology behind it?
As you mentioned, this is definitely not a relationship that's widely understood, and there's not really an evidence basis for explaining it. Although theoretically, when we think about pregnancy, we think about the immunosuppression that happens in order to allow the fetus to develop and protect it from the mom's own body. So there is thought to maybe be a relationship between that immunologic milieu that happens during pregnancy, as well as the physiologic process that allows for blood vessel growth. It's thought that this may make it easier for cancer cells to grow as well. Although, again, this hasn't been proven.
Gotcha. So it does make it very difficult to understand, not only for those of us in oncology that are caring for these patients, but even for those patients when you're trying to explain how all of this works.
Like most cancers, we don't really know why this happens. And that can be a difficult thing for patients and providers to cope with.
Absolutely. So when you do have a patient, a newly diagnosed patient, one of the first things that has to happen is that there's a lot of testing that's done, whether that's lab testing or different types of scans. What are the recommendations about pregnant patients with cancer and imaging?
So we know scans are an important part of the staging process for any kind of cancer diagnosis. In general, the main goal when we're scanning pregnant patients in any trimester is to avoid giving them any extra ionizing radiation, especially to the fetus, since we know from a lot of different studies that even small doses of radiation can cause birth defects, especially if the exposure happens early on in pregnancy during the first trimester. So instead of using PET scans or CT scans, which can deliver a pretty high dose of radiation, we tend to use MRIs and ultrasounds more often. MRIs are generally considered safe for use in pregnancy, although we would do these without contrast, since we know that gadolinium, which is typically used as contrast with MRIs, is teratogenic or it can cause birth defects. And ultrasounds we know can be safely used, although they are a little bit limited in terms of their utility in doing full body staging. And X-rays do emit radiation, but they can be used relatively safely as long as we use abdominal shielding to protect the fetus from any scattered rays. As opposed to a lot of other things, they're actually considered safer to use earlier in pregnancy. Since the fetus is smaller at this point, it's lower down near the uterus and there's less potential exposure. So for instance, if an X-ray was being used to examine a chest mass in a pregnant patient, it would actually be a little bit safer earlier on in pregnancy when the uterus is farther right away from that area.
Good things to think about. So you've got this newly diagnosed patient. They also are pregnant, and now you're starting to talk treatment options and things like that. What should healthcare providers consider about a patient's trimester when making cancer treatment recommendations?
So the most risky time during pregnancy for the fetus is in the first trimester, and in particular, weeks 2 through 8 of fetal development, when there's major organ development happening. We call this organogenesis. Chemotherapy is definitely not recommended in the first trimester, but actually is considered relatively safe in the second and third trimesters. Although, of course, we would want to monitor the fetus very closely for any complications. If patients are diagnosed in the first trimester, we hope that their treatment can be delayed as long as possible, ideally into the third trimester if possible, but as late into the second trimester as we can get. Otherwise, unfortunately, pregnancy termination does need to be an option early on if the mom's survival is at risk.
As a oncology nurse, you always work with a team. So there are always multidisciplinary team members that work together caring for our cancer patients. Are there any different disciplines that a nurse would want to make sure is now part of this team that is caring for a patient who is pregnant and getting ready to receive cancer treatment?
Caring for a pregnant patient with cancer is 100% a team approach. For instance, we had a patient in our practice who was being treated for Hodgkin lymphoma near the end of her second trimester. So she was about 29 weeks in. And besides her oncology team, so that was myself, the doctors, our nurse coordinators, her team also included high-risk obstetrics, maternal fetal medicine doctor, the pediatrics team, our social work team, who was really excellent, as well as nursing, the nurses in the infusion center, and as I mentioned, our nurse coordinator team. And I think most importantly, pharmacy, who we had to consult about pretty much every medication that we plan to give her, from our chemo doses down to Tylenol. This kind of collaborative approach is definitely doable out in community centers, but I think it's much more accessible at a big academic center. So that's why it is recommended that patients that are pregnant and diagnosed with cancer do get referred to these larger centers, just because of the ease of collaboration among all these different specialties.
That's a big team to try and make sure everybody understands and is on board with what's going on.
Yes.
That's a big ask for whoever is the organizer of making sure all of those team members stay informed and to make sure you have the best outcome for that patient as possible.
Yes, definitely a lot of moving parts, but that's always the goal.
Absolutely. As the oncology nurse with that patient, a lot. You've got that huge team that is discussing and making sure that everything is going as it should. But now we're talking about that oncology nurse who is right there with that patient all the time. How can they support pregnant patients as they're undergoing their treatment for cancer?
For our oncology nurses in the infusion centers that are going to be delivering chemo to these patients, they definitely want to pay close attention to the treatment orders and protocols that we're using, which might be tweaked slightly with either dose reductions or different rates of administrations, and they might be used to seeing for some of these more commonly used chemo regimens. So communicating with the treatment team is especially important. And nurses should, on the one hand, feel comfortable questioning orders, but on the other hand, be ready to educate themselves on what is safe and what's not during chemo for pregnant patients. Another thing to keep in mind is that there are normal physiologic changes in pregnancy that might overlap with some things we would expect to see from cancer or chemo related side effects, especially later in pregnancy. Anemia is pretty common just because of the hemodilution that occurs. Also, inflammatory markers like ESR or LDH on labs, which we monitor pretty frequently for Hodgkin and non-Hodgkin lymphoma, might be elevated just because of the pregnancy itself. So those are some things that nurses should look out for when they're reviewing the treatment orders and treatment plan in the patient's labs. Some of the other symptoms in pregnancy, just to go along with that, can also overlap with side effects from chemo. For instance, nausea, fatigue, constipation. Those are common in pregnancy, but also common in chemotherapy. And these may be actually potentiated when both of these are happening at the same time.
That's such a good point. As an oncology nurse, there are so many things that you have to be aware of. Like you mentioned, just the side effects of the treatment alone for a patient who doesn't have a pregnancy is a lot to follow, remember, kind of keep track of. But then you add in this next layer, it just really shows how important it is and how informed and educated oncology nurses need to be when they are caring for their patients. So we know that once a patient is diagnosed and a treatment plan is put into place, those treatment plans can last quite a long time. So you have a patient who is pregnant and they are going forward with their treatment plan, and the treatment plan extends beyond their pregnancy. So now let's talk a little bit about what are the guidelines for these patients and they want to breastfeed while undergoing chemotherapy. What does that look like?
In general, patients that are getting chemotherapy should not breastfeed because of the risk that the chemotherapies and the byproducts from these drugs breaking down in the body can be excreted through breast milk. Although different chemotherapies have different half-lives, so that also can be considered. But in general, the recommendation is that while chemotherapy is being received, women should not breastfeed. The pregnant patient that I had mentioned earlier that we were treating for Hodgkin lymphoma with ABVD, which is a pretty common chemo regimen for this diagnosis, she ended up needing to continue getting chemo after her delivery, and she was very determined to breastfeed. This was something that was culturally and personally very important to her. So we had to collaborate a lot with our pediatrics team in trying to figure out what the best recommendation for her would be. And ultimately, it was recommended that she wait 2 months after finishing her last chemo before breastfeeding. This patient was very, very determined to breastfeed. So she actually pumped and dumped to keep up her supply for about 4 months total, and eventually was able to breastfeed when her baby was about 6 months old. But Again, opting for formula feeding is a great option for a lot of women in this situation. And something else to be aware of is that there's a lot of pressure on moms in this country to breastfeed. We hear a lot of quote unquote breast is best. So it's important to be aware of this pressure and support these patients when we can in making what can feel like a really tough choice in caring for their babies.
That's so hard when they're having to deal with so many, just the normal kind of pressures and things that you put on yourself as a new mom. And then to have to deal with a treatment plan that is causing that. And also, like you mentioned, other pressures to continue breastfeeding or whatever that might be. And just how important it is for us to support them. So we've talked about after the pregnancy, there are a lot of complications that come with cancer treatment, or maybe not complications, but side effects and managing those kinds of things. So what are some of the postpartum risks or complications that can occur with a patient that has a cancer diagnosis and is receiving treatment?
Even before the postpartum period, we think that chemo is thought to be relatively safe for the fetus, as I mentioned, during the second and third trimesters, although there is still an increased risk for both intrauterine growth restriction and preterm labor that can obviously have implications for both mom and baby in the postpartum period. And most chemos, as we know, can increase the risk for both bleeding and infection because of the myelosuppression that can happen. That can make the delivery process itself risky for both mom and baby. So this is a situation where close collaboration with the high-risk OB team is especially important when planning the delivery. Usually, vaginal delivery is preferred, again, just because of the increased risk for bleeding and infection that can happen with a cesarean section delivery. And usually moms will be induced as close to their next planned cycle of chemo as possible. So that way we avoid having them deliver during the nadir window after chemo when their blood counts are thought to be at their lowest, and then therefore at increased risk for bleeding and infection because of anemia or thrombocytopenia or neutropenia. In addition to bleeding and infection, we know that pregnant and postpartum women are at increased risk for getting blood clots. So another thing that we do at our institution is for anybody, try to avoid placing central lines like PICC lines or ports if we can get away with it. This is especially important when we're treating a pregnant patient. So in the case that I had mentioned before, thankfully our patient had pretty good veins and this wasn't an issue. We were able to avoid placing a central line, but it's definitely something to consider because as we know, anytime you have a central line, you do have an increased risk for thrombus or for infection. If we do need to anticoagulate, we typically would choose Lovenox, which is the drug of choice since it does not cross the placenta and it has a relatively short half-life. And unrelated, but also related note, I think another important thing to mention is the health disparities that exist among women of color in terms of maternal health outcomes and also oncology outcomes in the US. We do know that Black mothers have a mortality rate that's about 3 times higher than white mothers and are also at higher risk for postpartum complications. And in the oncology setting, we know that Black women with breast cancer have worse outcomes with treatment and are also more likely to be diagnosed later on in their disease with more advanced stage cancer. So as nurses and APPs and other healthcare professionals, we all provide care to diverse populations, especially in this country. And it's important to be cognizant of the health disparities that exist and the potential barriers that they might pose to care.
Thank you so much for bringing that up. I think that's such an important piece that we remember. And you talked a little bit about when we were discussing the care team and just making sure that we have the right people involved in that. And That's a really good point. And looking at what some of those disparities are that our patients might experience and making sure that we have folks that are part of that team that can help us in identifying and helping those populations. So I know that, with a new mom and postpartum, normally without any extra stressors involved, there is a risk of them developing postpartum depression. So now we're going to add on this cancer diagnosis. Let's talk a little bit about what does that look like for the patients that you have seen as far as the risks and statistics of these patients developing or experiencing postpartum depression.
So, postpartum depression and anxiety are incredibly common and probably a lot more common than we think. And especially when you add on coping with a cancer diagnosis and undergoing treatment on top of being a new mom, as you mentioned, this is really something that we as providers need to be alert to. So I wasn't really able to find any data specifically looking at cancer patients in the postpartum period in their relative risk for depression and anxiety. But we know that in looking at postpartum depression, the general postpartum population, it's estimated that 1 in 7 to 1 in 9 women will experience clinical depression within the first year after giving birth. Postpartum anxiety often goes along with that. And the prevalence for that's estimated to be at about 15 to 25% of all women. So up to 1 in 4 women will experience some form of anxiety during that first year after birth. So that's a pretty significant amount. In looking at the cancer population, up to about a quarter of patients will experience clinical depression at some point in their cancer course. And again, I wasn't able to find any data specific to the prevalence of postpartum depression and anxiety in oncology patients, but you have to imagine that there's a lot of overlap and possibly even potentiation there. Definitely a situation where collaborating with your psychosocial services team is important to provide screening and referrals for additional mental health resources if needed.
I have to agree with you. I can only imagine that having those two things together, those two major life milestones, and you've got one that people think is a wonderful life milestone, and then one that, you would tend to think that people don't look at as a positive milestone with a cancer diagnosis, and put those two things together. And like you said, how they could potentiate a patient having depression and anxiety. It's just kind of unimaginable how much that would work on a patient. But you also just mentioned the psychosocial needs and support. How can oncology nurses support these patients during this time?
Supporting these patients is so important. Really, we want to make sure that we're screening these patients and screening them early at every visit, whether that's with a PHQ-2, PHQ-9, using any of the clinical tools and just checking in and being able to intervene early with medication and counseling if they meet the threshold for treatment. Since cancer in pregnancy is such a rare occurrence, as I mentioned earlier, only about 1 out of every 1,000 pregnancies, there probably won't be a lot of options for big in-person peer support groups. And especially during the pandemic, those were limited anyway. But there might be some good resources online for this. And I know where I work, our social work team is always really great with linking patients with these kind of resources, including financial resources as well, because we know that there definitely is financial toxicity associated with cancer. I would say most of the time, people that are pregnant in cancer are in the adolescent young adult group up to age 39 who are working, making money, and might be more at risk for financial toxicity than people in other groups.
Thank you. I think that that's really important. And again, just making sure you have the right people on that team to help those patients, and that we as oncology nurses know who it is that we can kind of direct them to and kind of know what our resources are for our patients too. Chandley, we're coming to the end of our time together, and I just want to thank you. This has gone really fast, even though it is a very small population of patients that our listeners could potentially see during their time as an oncology nurse. It's an important group to know and to understand some of those add-ons or special things that we need to be aware of with this patient population. So I have a couple of questions that I always end our podcast with, and I'm just going to ask them to you in a real quick fire manner. And the first one I have for you would be, what are some common misconceptions about pregnant patients with cancer?
So one of the things that I was surprised by in my experience treating pregnant patients with cancer was the fact that we could treat them. We've gotten really used to the idea that a lot of medications, even a lot of foods are off limit in pregnancy, but in reality, a lot are okay, although sometimes at a reduced dose. So even drugs that are pregnancy category B and C are pretty safe. So for instance, we would routinely give steroids prior to chemo infusions for nausea prevention. And normally we would try to avoid giving those in pregnancy, but in lower doses, they're actually considered pretty safe. Another thing is the importance of COVID vaccination in this group. There's a lot of misinformation about the safety of the mRNA vaccines in particular, and the risk for infertility or miscarriage, and that's been unfounded. But we do know that pregnant women are at an increased risk for severe illness if they do get COVID. So it's definitely important to recommend vaccination for this group. Ideally, they would get at least one dose of one of the vaccines prior to starting treatment. In general, even though this is a pretty serious situation with a lot of implications, the good news is that the data tells us that the outcomes for pregnant women with breast cancer and lymphoma in particular are just as good for women who are not pregnant. And in general, the babies of these women do really well, although with close monitoring and early intervention if needed.
What's something about this topic that's not often discussed, but you wish people knew more about?
Just to go back to the psychosocial implications of pregnancy and cancer, we talked about postpartum depression and anxiety and the fact that these conditions might be potentiated by the cancer diagnosis. And again, I think we as providers need to be cognizant of the fact that the experiences of going through a cancer diagnosis and treatment and also going through a high-risk pregnancy and childbirth itself can be very traumatic events. We don't need to know how to manage PTSD or post-traumatic stress disorder, but we do need to know how to ask the right questions and refer when appropriate. There was one study that estimated that about 1 in 4 women with breast cancer can experience PTSD. We know that PTSD can be a side effect from the childbirth experience alone. So again, this is something we need to be aware of in this special population, especially when they are transitioning from active treatment to the survivorship period, which can be tough for any cancer patient, let alone one trying to navigate that and the demands of motherhood. And then just to finish that thought, one of the drivers of PTSD we know is the feeling of powerlessness. So I think involving patients in their care as much as possible can definitely be helpful in helping them maintain their agency and hopefully helping to mitigate some of those effects.
What additional training or resources do oncology nurses or providers need to care for patients who are pregnant with cancer?
There aren't any special certifications or courses that I'm aware of for this, likely again, because this is such a rare occurrence that a lot of oncology nurses won't necessarily come across that frequently. But again, I think it's important for nurses to be aware of the resources that their facilities may have available, such as support groups or online academic resources for nurses to look up drug interactions or find academic articles. In general, you just want to be aware of your institution's protocols around chemo administration and safety rules to be able to provide safe care for any patient.
And finally, what are some additional resources for patients who want to learn more?
For patients, as I mentioned, peer support groups can be really, really helpful. Although for pandemic reasons, and again, because this is a rare occurrence to have pregnancy and cancer occurring at the same time, they'll probably need to seek those out online. But the social services team at any facility is going to be a really good resource for patients and linking them up with those resources.
Chandley, thank you so much for being with us today. I think that our listeners are going to really appreciate the information that you have shared with us, and it will be extremely helpful. Do you have any final comments for us?
Yeah, I just want to say thank you for letting me come on and talk about this complex and sometimes fraught topic, and hopefully allowing me to shed a little bit of light on it and educating our audience.
Thank you so much. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.